about other agents, Karen, in the same population, particularly MET inhibitors? What's your take on that, and where do you think we're going?
So especially in combination with erlotinib, there's been a lot of work looking at MET inhibitors, specifically ornituzumab, the METmab, and the
Tivantinib, right, the marquee
right, the tivantinib
agent.
drug. So the ornituzumab is in a phase 2 trial, showed improved progression-free survival with the combination of erlotinib and the drug in patients who had overexpression of MET. And that's an ongoing phase 3 trial now with the combination versus erlotinib alone in patients that overexpress MET. The marquee trial was the phase 3 trial with tivantinib and was closed early due to futility. And so that was a trial that did not show benefit to the drug plus erlotinib versus erlotinib alone.
Although I don't think we've ever seen those data presented.
We have not yet seen those data.
Which is sort of frustrating, isn't it? So, but both those, the tivantinib trial did not require separate MET testing.
There was not MET testing
But the onartuzumab trial, the METmab, the phase 3 trial, mandated MET positivity,
Yes.
and this was an IHC
Right.
assay.
And I think this is really obviously where we need to go, is trying to find these markers to try and best target the specific patients where they're going
But
to
again,
benefit.
this is an unselected population. These are not necessarily EGFR mutant patients.
They are not. They are not.
So Anne, same patient, but a different wrinkle. The biopsies, the mediastinal nodal biopsies returned positive for EML4 ALK translocation. Granted, a past smoker, but female adenocarcinoma. How would you handle
Doesn't
that
matter.
patient?
Yeah. If they have the EML4 ALK translocation, I always start off with crizotinib. Whether it's frontline or second line or third line, obviously these are patients we want to identify early. We know that EML4 ALK is a negative prognostic indicator from retrospective studies that Alice Shaw has presented at ASCO. And so we need to identify them quickly and get them on the treatment, which is crizotinib. Now, obviously, there are some patients that are resistant to crizotinib, and there are a whole host of second-generation inhibitors, the LDK378, the AP26113, the Chugai agent. All of those are potential options for them in the future. But for this patient right now, first thing I would do is get them on crizotinib.
So if you could just recap the profile trial. It was presented
So,
actually originally last year, but it wasn't first line, it was second
yeah, it was
line.
actually second line, but it still got the indication for first line because biology seems to trump everything here. And so this was a study that was a phase 3 trial, I believe, that was comparing in the EML4 ALK population, giving them crizotinib versus the docetaxel or pemetrexed. And it clearly showed significant benefit, hands down. So
Much higher response rate.
Much higher, progression-free survival was much better. And so because of that, the FDA did approve crizotinib for any EML4 ALK, any line of therapy. So.
And an intriguing sidebar from that trial was the observation that pemetrexed seemed to work a bit better than docetaxel. Granted, they weren't compared to each other, but both response rates and PFS were higher.
Yeah,
Why do you think that's the case?
There was actually just a publication that came out in JTO as well. The precise mechanism of action I'm not quite clear on, but it's definitely something that's been, observed in several different studies as well.
So